Today we are pleased to launch a new series called Our Healthy Community. And we want to thank our presenting sponsors for Our Healthy Community series, OhioHealth, represented by David Blom, President and CEO of OhioHealth, Bricker and Eckler, represented by Jim Flynn, Chair, doing well, Flynn, Chair in Healthcare of the Healthcare Group and his colleagues. We also want to thank KeyBank, represented by Melissa Ingwertson and her associates, as well as Corna Kosing, represented by President Mark Corna and his associates, for the support for today's forum. Please, let's thank them all. A biography of each of the speakers is in your forum flyers, so in interest of time, I'll provide only brief introductions. Our first presenter began his career with OhioHealth in 1983 and has held progressive management positions, leading to his appointment as President and CEO in March 2002. Please welcome David Blom. Our next panelist is an OBGYN and one of the world's leading experts on the complications of diabetes and pregnancy. Since April 2008, he has served as CEO of The Ohio State University Wexner Medical Center and Senior Vice President of Health Sciences for The Ohio State University. Please welcome Steve Gabbe. Our next panelist is board certified in anesthesiology and critical care medicine. He became CEO of Nationwide Children's Hospital on July 1, 2006. Please welcome Steve Allen. Finally, our next panelist has successfully held positions in hospital administration in other communities prior to his appointment as President and CEO of Mount Carmel Health System in August 2006. Please welcome Claus von Zychlin. On behalf of the Metropolitan Club, OhioHealth, Bricker and Eckler, KeyBank, Corning Kokosi, please welcome all our panelists. And David, the microphone is now yours.
Thank you, Rich. It's nice to see so many people here. We were speculating a little bit before the meeting as to why there's so many people here. Whether it's healthcare reform or the Medicaid budget, or whether it's the complicated business environment in which the four of us operate, or if it's just a personal matter for healthcare for you, and it's probably some of all of that. So thanks for being here. We should count ourselves as fortunate that we live in a community with 4 really good health systems. Not every city can say that. And when I say really good health systems, I mean that by almost any definition, whether it's the quality of the business enterprise, or whether it's the quality of the care or the quality of the doctors. We're fortunate in Central Ohio to have 4 really good health systems. And we also are fortunate that we work together. It doesn't always feel that way, but usually we do work together. And Jeff Kingler, where are you, Jeff? There he's Jeff. Jeff runs the Central Ohio Hospital Council for us, and he kind of helps us move through a common agenda together, and he does a really good job at that. What we focus on, you're going to hear about today. It's on quality, it's on access, it's on value, and we have an agenda that keeps us focused on those things jointly. Today you're going to hear a little bit about several projects that we're working on, but the most recent project is HealthMap 2013. You've got it in front of you. It's a community needs assessment that we've all worked on together, and Dr. Gabbe from Wexner Medical Center is going to talk to you about that in just a moment. Then Dr. Allen from Nationwide is going to share with you on work we're doing on a preterm birth initiative, which is kind of cool. And then finally, Claus von Zychlin from Mount Carmel will give an overview of the mental health inpatient placement program that's being coordinated through Central Ohio Hospital Council, something very unique to Columbus, Ohio. So with that, we'll get started and save a little time for questions at the end. Dr. Gabbe.
Thanks so much, Dave, and I'm very happy to be able to share with you the results of the Franklin County HealthMap for 2013. The Patient Protection and Affordable Care Act required hospitals to conduct a community health needs assessment and then to implement strategies to address the findings in their assessments. Our 4 Columbus hospital systems agreed that it would be much better, as Dave has described, to do a single assessment that would serve our community rather than do 4 separate evaluations. And that's what the council agreed to do. We're jointly releasing this assessment, which is the result of a collaborative process that's been carried out over the past 18 months. And I want to acknowledge the community organizations that participated in this assessment, and we all want to thank them for their help. This is the Columbus Public Health, the Franklin County Public Health, the United Way of Central Ohio, the Columbus Neighborhood Health Centers, the Lower Lights Christian Health Center, the Heart of Ohio Family Health Centers, the Ohio State University College of Public Health, the Central Ohio Trauma System. In developing our assessment, first we wanted to put together a single data set that would help our health systems and other healthcare providers better understand what exactly the needs of our community would be. What are the priorities for healthcare need for Franklin County's residents? We wanted to help healthcare providers then develop strategies to address these healthcare needs. And in developing this assessment, as I said, we wanted to have a broad group of organizations that would represent our community. Now, as you look at the health map, you'll see that there are 8 priority areas: access to care, chronic disease, infectious disease, behavioral health, which you'll hear about from Claus, the high incidence of cancer in our community, interpersonal violence, high-risk pregnancy, and Steve is going to touch on that, and unintentional injuries. When you look at this data, you'll see data for Franklin County and for Ohio. Let me put this in perspective. Ohio is ranked 35th in the nation when it comes to how healthy the state's residents are. 35th in the nation. This is from the United Health Foundation's America's Health Rankings. So when you look at Franklin County and you see we're as good as Ohio, that's not very good. And when you look at Franklin County and you see we're not as good as Ohio, that's pretty bad. So to put it in summary, we have a long way to go to be a healthier county. Let me talk to you about some of the specific issues. In terms of access to care, almost 20% of non-Medicare adults in our community didn't get dental care last year. Folks in Franklin County use emergency rooms at a higher rate than do folks across the state of Ohio, and they use the emergency departments for less severe cases. We can talk about why that is later. Leading cause of death in Franklin County, as we look at chronic diseases, leading cause of death is cancer, and that's followed by heart disease and lower respiratory disease, lower respiratory tract diseases. Hypertension is responsible for the most hospitalizations in our county, in Franklin County. If we look at infectious diseases, our county has a higher rate of sexually transmitted diseases than does the rest of the state. If we look at behavioral health, and you'll hear more about this from Claus, smoking in Franklin County occurs in 18+% of our residents. That's a little lower than the state of Ohio, but it is higher than the national rate of 17%. Other issues around behavioral health, the suicide rate in Franklin County is higher than the rest of the state, especially in the ages of 15 through 24, and especially in men. The suicide rate in Franklin County among men is 4 times that seen in women. Now, if we look at cancer, which, as I said, the leading cause of death in our county, this is especially true in lung, breast, and pancreas, where the death rates are higher, but somewhat lower in liver and colon cancer. Now, one area that we do well in, is in screenings for cancer. In cervical, breast, colorectal cancers, our rates are better than the state, and they're better than national averages. We had a much higher homicide rate than that seen in the state. As we look at interpersonal violence, and Franklin County adults have a higher percentage of being a victim of violence than does the rest of the state. I won't comment on high-risk pregnancy because, as I said, Steve is going to make some important points in that area. Finally, if we look at unintentional injuries, they are the leading cause of death for children ages 1 through 14. The leading cause of death, unintentional injuries, including motor vehicle accidents, falls, those things. And finally, the highest rates of hospitalization as a result of unintentional injuries are seen in our older residents, folks age 75 or older. So I hope you review the health map, and I think you'll find it really interesting. It's something we will do every 3 years, and we certainly welcome your feedback about this process. If you'd like to hear more about the results of the health map survey, we're going to have a community discussion at 9 o'clock Thursday morning, February 14th, at the Mid-Ohio Food Bank in Grove City, and we hope you'll join us for that, and there are invitations for this event at your table. This discussion will enable us to take our conversation about the needs of our residents to an even greater in-depth level. With that, I'd like to turn the microphone over to my friend and colleague, Steve Allen. Steve?
Thank you very much, Steve. Well, I have the marvelous pleasure to get to talk to you about some of the results of the collaboration that goes on not only between the 4 health systems here in Central Ohio, but it also couldn't be done without the collaboration of a number of our community partner organizations in town. And I'm going to just give you some highlights on one of our programs that deals with trying to reduce the incidence of prematurity. The thing that I think that people here don't fully understand, of which I get to brag about around the country, is how all 4 health systems in town have gotten together, put their competitive issues aside, and gone after a public health issue that has dramatic impact on our community, that has been able to begin to bend the needle in some early pilot projects. And many of us have worked in healthcare systems around the country. None of us can think of another community where you could get everybody to work together in such a collaborative fashion. And to me, it just speaks so well to the aspiration that this community has and the health system's intent in their nonprofit ways to help reflect that back to the community. Well, I'm going to talk about, the first thing I'm going to talk about is prematurity. So as some of you in the audience know, we have an infant mortality rate in this country, and certainly in Central Ohio, that's on the level of some developing countries. It's high, it's way too high, and for the last number of years, it's been going up across all demographic groups. The reason why our infant mortality is high has a number of causes, but the single most important factor that drives it is that we have too many babies that come too early. Our incidence of children who are born premature is too high. It has enormous impacts on our community. One, these babies require a lot of care, which I'll talk about in a little bit, but not only after they get out of the hospital, after they've gotten through their first several weeks of life, often, particularly the severely premature, have other problems with them that require lifelong therapy to support and help. So just add a number of burdens, not just financial, but socially, on our economy. So beginning in April of 2009, the 4 hospital systems, along with the Columbus Public Health Department, as well as community health centers, got together to form an organization we call Ohio Better Birth Outcomes, or OBO. And this is an initiative now that has started some small pilot projects that I think have had some really significant results. It turns out, this first project that I'll talk to you about, it turns out that my esteemed colleague, Dr. Gabbe, in his academic pursuits of trying to figure out a better way to take care of pregnant women, published a paper in 2005 that showed that if you took women who had had a premature birth previously, they have a 75% chance of their next pregnancy also delivering prematurely. And in this study, they found that if you took these women and started administering a medication to them of a type of progesterone, a hormone, that you could prolong their subsequent pregnancy by a substantial amount. So it was an evidence-based intervention. The problem with a lot of things that we need to do in order to improve the health of our community, it's one thing to know what the right medicine is or the right procedure. It's another one to construct a healthcare infrastructure in the community so that it's delivered appropriately and repetitively and correctly time and time again. So we knew the right intervention to do in these high-risk women, so we had to put together a community organization, engage all the providers in town, particularly those who might have early access to these women early in their pregnancy, to try to get them in. Then this group, OBO, then developed a protocol where all the providers could use to screen particular women, and then through the Central Ohio Hospital Collaborative, developed a database so we could track these women and find out where we can have opportunities to improve our ability to deliver this care. So subsequently, we've now done this now for a few years, and on average, we've been able to prolong the subsequent gestation, the subsequent pregnancy, by an average of 7 weeks compared to their previous one. Now, that doesn't necessarily mean we get all of them to deliver at term, but it certainly means that instead of delivering a baby severely preterm, we have one who's much less likely to suffer the long-term sequela. And the results have just really been very gratifying. To put a financial term on it, the average cost of a baby who has to go to the neonatal intensive care unit is around $38,000. That compares to the cost of a normal delivery, which is around $1,300. But then again, it's about how much it costs to take care of these kids after they get out of the hospital the first time, and having the support to deal with all the problems that come from that. So this, to me, shows what a pilot project like this can do in a community like this, affecting large number of people, often who don't have the best access to health care, as many of you in this room do. And we have plans where we're going to expand this, continue it, to try to have a greater impact on the community. The second area that I was asked to talk about is our initiatives around breastfeeding. I can't give you personal recommendations on it, but I have 5 children, and I can speak to where I think it did them a lot of good. So breastfeeding just has an enormous number of positive attributes, and the incidence of which we get women to breastfeed their babies just isn't at the level that we'd like it to be in this country. Breastfeeding protects babies from infections and illnesses, such as diarrhea or ear infections or inflammatory bowel disease. Babies who are breastfed are less likely to develop asthma. They're less likely to be admitted to the hospital for routine illnesses. Babies who are breastfed for at least 6 months are less likely to become obese, less likely to develop type 2 diabetes. Breastfeeding has been shown that it reduces the incidence of sudden infant death syndrome, and mothers who breastfeed have been shown to have a decreased incidence of ovarian and breast cancers. So there's just a lot of attributes that the community derives by encouraging breastfeeding. But we know that it's not where it needs to be. So we did a survey of about 600 women who agreed to participate as to what they saw the obstacles were toward breastfeeding. And above and beyond any other factor, it was their concerns about having to go back to work or to school impacted their ability to continue to breastfeed. So under the Central Ohio Hospital Collaborative's guidance, we're developing a set of guidelines regarding, first, in hospitals' inpatient practices. We need to figure out ways how we can best support women to initiate and sustain breastfeeding after the baby is born. And we're also working to develop some guidelines and best practices to roll out to employers and schools here in town so that we can help them develop the wherewithal to support these women in their breastfeeding. Moving toward where we hope that we can get people to sign on to an employer's pledge about being a place that's supportive of breastfeeding. It has benefits not only to the babies, but I'd say that to the employers, the benefits is that these children just tend to be healthier, so it is likely that those employees will have to miss less work or less time from school in order to be providing for care for those kids. So I think that's just a couple of initiatives that I hope convey some of the great collaborative work that's gone in this community. And we have another one related to mental health that my colleague Claus is going to talk about.
Thanks, Steve. So as Dave and Steve have said, I've been here now almost 7 years, and one thing that I found impressive is coming in here, probably within the first month that I was here, the four of us came together, and we set a couple of principles up, which included the fact that we needed to meet, and as non-for-profits, we had a responsibility to provide and to work together to provide services in this community, recognizing that we also would be competitive in many different ways. And so we've stuck with that tenet, including the fact that when we meet, we require that each of us be there and that we don't send others in our organization who obviously are qualified to speak to some of these things, but the fact that we as the leaders of our organizations participate and hold each other accountable to the types of outcomes and the type of processes that we are sharing with you today. So I'm going to briefly talk about a couple of areas in quality that we have been working on. And some of the things that we've done I find also good is that we have decided to work on these projects in a way that has helped us individually get better and in turn has worked in the community, and have not used them at this point to try to outcompete each other from a marketing point of view or an advertising point of view. And that's probably one of our successes, is that we've been able to hold each other accountable to some of these processes and have gotten better that way. And hand washing is one of those examples. So we've formed this collaborative where we have been working on things like heart failure, heart attacks, pneumonia, surgical care, hospital-acquired infections, and preterm births, as Dr. Allen has spoken to you. In something like hand washing, that most industries probably have their own little skeletons that happen within their industry. And if you look at the healthcare industry, we know factually, more so the physicians, but we also know that germs get transmitted by lots of different things, including not washing hands. And yet, if you look at the national average of hand washing, around, it's about 50%, plus or minus something in that range. And we were really no different in that range in this community than the national average. And I think in the work that we've done collectively, we are now approaching 90% and will soon get above 90% on that work. And we've done that by collaboration, including the fact that we have worked together where we have trained secret shoppers who go into each of our facilities, and they monitor on a common set of factors how and why the physicians that work at each of our facilities, our staff, how they go about doing their hand washing. And so I think in that work, and keeping it and working with one another and holding each other accountable, we've been able to get that process done now in a remarkable short period of time. So an example of how that's virtually we've seen virtually a 200% improvement of where we were when we started to where we are today. Just a phenomenal opportunity that we work together on it, and in return, how we can improve care to this community. The second one that also fits in the category of collaboration is mental health. When we started here probably 5 years ago, a challenge there are not enough psych beds, and there are a number of reasons why psych is such a challenging, psychiatric patients are such a challenge in this community, and they are in most other communities. But it was not uncommon that in any one of our emergency departments that we would have psychiatric patients who are waiting for disposition to be in there greater than 24 hours, 36 hours, even up 48 hours. I think at one point we had a record somewhere in the neighborhood of 4 days. And so we said that this is something that we can work together on and try to improve how we provide that care in this community. And so we worked with between Mount Carmel, OhioHealth, the OSU Wexner Medical Center, NetCare, and Twin Valley Behavioral Health Care. We started working with that single goal in mind: how can we create a better process in this community for transitioning patients through the system? And so we began to work in a way that ultimately now we also have 2 of the for-profit psych hospitals in town, Ohio Hospital for Psychiatry and Dublin Springs as part of that. And with the support of the Columbus Foundation, we developed a bedboard system, a system that every morning there's a staffing where the staff from each of our emergency departments through the bed board know what patients in each one of our emergency departments are waiting for a disposition of psychiatric care. And through that process, they prioritize those patients, and regardless of which emergency department that patient is in, when we have an open psychiatric bed among our areas, the patient that has the highest need gets that bed. So if I happen to have a bed available in my psychiatry unit and I have a patient in my emergency department, but the highest use or the highest demand patient is at an OhioHealth facility, they in fact will get that bed while our patient is waiting for the next available bed to drive that process. And so if we look at where we're at today, in 2009, the number of ED patients needing psychiatric care rose from just under 400 a month to 840 a month. That's a 110% increase in that growth. Despite this increase, we've now reduced the wait time to under 24 hours through this coordinated process. So we feel like these types of things are in fact in the best interest of the patients we serve in this community and in the best interest to the community as a whole. And so we are committed to continuing to work on projects like this, and that actually is supported by this health assessment that we did. We looked at it not as something that's just required by us to do through the federal government in the 1990s, but actually as a vehicle through which we can continue to work on priorities and collaborate. So with that, I will turn it over to Dave.
Thanks. So a lot of good work. Obviously, it goes without saying, a lot more to do. I think the challenges of healthcare in the ensuing today and in the ensuing years become even greater. Healthcare is 18% of our gross national product, and federal and state deficit budgets are not going to be dealt with without dealing with healthcare. So it's going to challenge us all to work together. When I say all, I mean all of us to work together to help solve the problem, whether it's consumers, whether it's providers, or whether it's the financing mechanism. We're all going to have to find a way to deal with the healthcare issues differently than we have thus far. I think the HealthMap is a good underlying document to help us identify some of the underlying issues. And I think it gives us an agenda that we can work on collectively for the future. So with that, Rich, I'll turn it back over to you.
Thank you, gentlemen. We always have a period of questions and answers here at the Metropolitan Club. That's part of what the civic discourse is all about. So we ask you to approach the microphone, if you will. State your name. Refrain from taking the time to do any editorial comments. Make sure it's a question, and you can address any of these gentlemen. George?
George O'Donnell, CMC trustee. In a book, The Emperor of Malady describes cancer as the emperor of malady. And I'm asking you, gentlemen, please, to think about what could be bumping cancer from the emperor position. Would it be obesity? And how will we see that problem manifested in the next 15, 20 years with the system that we see taking place?
So I think your question is, if cancer were not the leading cause of deaths, which it is, and by the way, that's a great book, what is our next major health issue to deal with?
Yes, Dr. Gabbe, that would be, is obesity going to be bumping cancer?
Yeah. Most of our health-related problems today are behavioral in nature. So if we're going to improve the health outcomes in our country, we're going to have to focus on eating a better diet, exercise, weight loss, smoking, alcohol, substance abuse, violence. Those are the major issues. We all talk about healthcare delivery systems, and that's so important, but it's what people do every day that ultimately must be addressed. And that's a challenge we have not done well with in this country. That's where we have to focus our efforts. Not sick care, but well care.
Hi, Jim Flynn is the pronunciation I favor, Rich, from Brickert Eckler. And first of all, I applaud you for your efforts in collaboration and your commitment and results from it. Two questions, one related to the needs assessment, one maybe slightly off topic from that, but taking advantage of your collective presence with us here today. First, on the needs assessment, do you feel like you have the same commitment from the physician community that you as organizations have expressed towards these needs and towards addressing these needs? And then secondly, front page, top of the fold yesterday, Medicaid expansion. I just wondered if maybe any of you could share some of your views about that, particularly as it affects our community, your institutions, and the patients that you serve. Thanks.
I'm happy to talk for physicians, but I think this is exactly why those of us who go into medicine do it for, and that's to try to make a difference in our community, make people better, decrease the burden of disease in our community. So we get nothing other than impatience. I have some of my physicians here in the back who want to know why we can't move some of the stuff faster. So I think this just lines up for those of us who've chosen this to be our life's vocation. This is right in the sweet spot.
So with respect to Medicaid expansion, the Ohio Hospital Association was here. I know the four of us all are behind the governor with Medicaid expansion. You can debate the numbers plus or minus for it, but the fact is, if you don't have patients that are covered, you don't have a predictable use of the system, you don't have a list of enrolled people that you can help manage their health care. So folks just have episodic, uncoordinated use of the healthcare system. You can't manage the costs. You can't manage the care. So having them engaged and enrolled in some predictable fashion is going to be an absolute imperative to help managing the cost of that system, which is a little out of control.
I think the HealthMap showed that. I mentioned that folks in Franklin County use the emergency department more often than the folks in the rest of the state, and they do it for less severe issues because, as Dave has said, they don't have another place to go for their care.
And go ahead.
As David said, the primary issue is how we do on patient care, but also if you look at the broader picture of the Accountable Care Act, it is also part of how the funding mechanism works. It's integrated with the funding cuts that were made in other ways, and so it's all part of the bigger picture. And if that expansion doesn't go through, it takes out one portion of the realignment of some of the financial aspects of the Accountable Care Act.
One more comment about Jim's question about physicians being engaged in these issues. I think you're hearing more about and finding more physicians that are becoming aligned with their hospital of choice or their or the organization of choice. And what I think we're all finding is, unless you have the physicians and the hospital institutions aligned, you can't deal with these issues effectively. You're all watching out for your parochial interests. And having that alignment to find a common agenda, again, is another something that we have to do to deal with some of these issues that we've actually talked about today.
John.
Thank you. Good afternoon, John Carney. I'm a healthcare attorney at Porter Wright. I'm a member of the General Assembly as well. One of the things that we're struggling with in the General Assembly is the fact that Medicaid is about 40% of our budget, and obviously the cost of that is outpacing inflation right now. And I guess from your perspective, what incentives or disincentives do you think we could build into the Medicaid system to help start to contain those costs? In the short term with Medicaid expansion, the federal government will pick up the cost, but eventually that cost is going to come back on the state of Ohio. And to be frank, the state's struggling with just managing the cost we have with the lives we have on that program right now. It would seem that you all are in the best place to give us some insight with respect to what we could do to maybe provide some tough love to the folks on the program to hopefully start to contain some of those costs.
Well, thanks for your question, and thanks also for your support of Children's Hospital particularly. The Medicaid particularly, I guess I got chosen to ask because Medicaid makes that such a big part of children's business. The reality is that on the average, and nationwide children's is no different, over half of the patients we take care of are covered by Medicaid. So Medicaid is a critically important part of how it is we're able to meet the mission of the hospital. The interesting thing is about Medicaid for children, though, is that although children end up making up about 70% of the beneficiaries, they only consume about 30% of the costs. So we're in kind of a little bit of a unique part of that angle. The way that we have chosen to pursue it in Nationwide Children's through some marvelous initiative efforts starting about 15 years ago by our CFO, Tim Robinson, who's in the back there, was to begin to go at risk. One of the things that I think troubles physicians of my generation is that the incentives for how we get paid to take care of patients are often, if you will, perverse in nature. Often we're incentivized to go after and seek the next more and sicker patient rather than produce fewer of them. So under Tim's guidance, we formed a physician hospital organization where we go at risk to take care of about 300,000 children now in Central and Southeast Ohio. Our incentives then are reversed. We're incentivized to improve their health care and decrease the cost of utilization. And to me, Representative Carney, it takes new types of reimbursement models, payment models, incentives for the healthcare system to begin to do things more along the direction that you want to do. Now, ours is just one example. There's any number of other possibilities of bundled payments and other things that could be entertained. But to me, until there's some change in the way that the reimbursement model makes, you can't expect the behavior of the providers to be remarkably different.
Carol McGuire, I'd like to thank you all very much for being here today and express my appreciation for your ability to all get along so beautifully and collaboratively. It certainly serves the citizens of Central Ohio quite well. I note that the study was specifically stated as Franklin County, and of course I believe we are such an integrated region here that my question is, are you going to expand beyond Franklin County and do additional research in the contiguous counties, or is that really a part of what's been done up to this point? Certainly I know all the health systems up there serve a much broader footprint. Thank you.
So I'm going to take a shot at this because we haven't talked about that yet. Okay. We have so much to do just within our primary and maybe even secondary market. And you know, we also have the Ohio Hospital Association that also has done work in this area and will continue to evolve. So I think I don't think in any way, shape, or form we would have any reason not to, but we also have a lot of work to do, as you know, just as you can see for the numbers within the markets that we are. But we would certainly encourage others to do it, and/or we would not discourage anyone to joining us in helping make this become more a greater community project.
Good afternoon. I'm Bill Hutter. I would like someone to comment on the idea of having a regional health information exchange organization. Is there any talk about commonality of records platforms, electronic medical records, to facilitate lower cost of the administrative part of this, especially from a patient perspective?
You know, we've been talking about that for a long time.
I know.
And it's hard to do. It's really expensive. It's hard to find somebody to pay for it. There are a number of states, a number of cities. I think Cincinnati did it, right, Claus? There's a number of cities that have done that, but it's hard to keep it going because of the expense involved. What seems to be occurring with the information systems that are available today and becoming available is, I'll use the wrong term, but the interoperability or the connection between these large systems. And I think the health information exchange will occur in that way rather than building a central infrastructure and have everything feed it and then go back out again. I think what will occur, at least in this community, in the not too distant future, will be all of our systems will be able to talk to each other. That will achieve the goal.
Well, Jane Scott, we actually have some extra time, so there's no way we're going to let you go early. So I have a couple questions for you, really. Number one, you said you're going to redo the study in 3 years, so I'll stick my neck out and invite you back in 3 years to let us know how we've done as a community. And number two, you know, most of us in this room have seen in our lifetime a remarkable change of behavior and attitudes and cultural attitudes in smoking. How do we achieve the same behavioral difference in terms of obesity, some of the other issues? It just tears me apart to think that so many of our health issues are behavioral. And we know how to change those, or don't we?
Oh, well, I guess I'm going to talk a little bit about obesity in children, and there's some relevance to that because if you're heavy when you're 10 years old, you have an 80% chance that you're going to be heavy when you're an adult. There's a lot of structural issues around that. We have a number of initiatives where we've tried to deal with it at a childhood level, but it's things around the built environment. We have some pilots that show that it makes a difference. We have a couple where we go into elementary schools and after school, and then through the summer program of 90 minutes of physical exercise and then a half hour of nutritional education. And the physical exercise is great. We can document that we improve their physical fitness, but the nutritional education, even to a 10-year-old, is important because kids eat what their parents put in front of them. So we know this works because parents will call us and complain that we're telling their kids that they're putting bad food in front of their table. So, you know, when you look at that, then you have to figure out. And then, you know, when we talk to the parents, they say, well, I don't have access. I'm in a food desert, a grocery desert. I don't have access to fresh fruits and vegetables. That's an aspect that we have to deal with. There's another one that's really interesting. I had two parents say, I said, you know, how do they don't eat their vegetables? I said, well, they don't like their vegetables. I said, well, what kind of vegetables do you like? He says, well, I don't like vegetables either. And part of that is just amazingly, a lot of people just haven't learned how to prepare them in a way that are appealing and make it part of a diet. So I think there's some other issues just with access to physical exercise, role model, but that's a community-wide initiative. I think we have a number of really good partners in town that are beginning to work on it, but that's a great one for this community to take on. Great question.
I will add on to that. You know, there are some employers, some health plans are finding ways to deal with that by providing the appropriate incentives in their plan design for wellness and health. If you have a high deductible health plan and you're overweight, you know you're going to have health issues. And I know just from our own health plan at OhioHealth, we've made a big impact on changing the weight of our associates. How many pounds did you lose, Mike? We lost 27,000 pounds of, I think we lost 150 people. Yeah. But there was an interesting story. We have a nurse named Karen who I was talking to, and she said she's very heavy. She said, I need to gain 7 more pounds so I can qualify for gastric bypass surgery. I said, are you kidding me? Well, she got into a program where she's lost the weight, and she's no longer has a whole host of problems that she had. So it's a personal responsibility issue that can be enhanced through the appropriate incentives.
Good afternoon. Daily, I'm reminded of how strong our healthcare system is. When you drive anywhere, there's construction. We have a brand new building, and you guys are all collectively investing significant dollars in our region and our city. So I just wanted to hear a little bit more about the exciting things. I know we're talking about a lot of serious stuff and how we all need to develop better habits. But I was thinking that maybe we could hear a little bit about the collective investment that you guys are doing and how you're bringing such great talent to the region. And if you could take a few minutes to share more, that'd be great.
Well, I think you might ask, why are we all doing this? What is the reason for it? And, you know, we are fortunate to be in a community that's growing, and we're also in a community that's aging, and we're also in a community where many of our health systems have semi-private accommodations, which not only aren't acceptable to our patients and their families, but are not as safe as being in a single room. So, you know, we're looking at providing the capacity that we will need for our aging population, who unfortunately will continue to be troubled with cancer and heart disease and neurologic problems in the years ahead. You know, we're building our new James Cancer Hospital on the site of what was a tuberculosis hospital. And we took it down because we don't need it anymore. And we would hope that one day we will live in a cancer-free world and we won't need the new James. But unfortunately, as we learn more and more about cancer, and we realize that everyone's cancer is different from everyone else's cancer, and that the approach to this must be a very sophisticated genetic analysis of that individual's tumor, and then, if it spreads, those metastases, we have a real struggle ahead of us. Yes, the mortality from cancer is declining. Yes, we have more and more cancer survivors. But some of the behavioral risk factors, the aging, the growth of our population demand that we can provide care for the patients in our county. We're seeing at Ohio State a remarkable transformation in what's happening with people who want to come here. And I'll say they want to come to Columbus. They realize we have great opportunities for them and their families. And we're having folks from some of those prestigious universities in the country contact us and say, we'd like to come and be a part of the exciting healthcare growth in your community. And that's just going to be better and better for all of us. So it's an exciting time to be in healthcare in Columbus and in Franklin County.
Well, I think it was, he may not have been the first, but certainly Abraham Lincoln came up with the idea of putting together a team of rivals to get some really good stuff. And I think you guys demonstrate that that was not a bad plan. Thanks so much for being here today and sharing all the information. I hope this overflow crowd enjoyed the program today, and you're welcome to join these guys and others out in the lobby for coffee and cookies and continue the conversation. We're very green around here. We recycle name tags, so don't forget to put your name tag in the basket. If you're interested in membership, put your card in there. Again, we're losing the group, but thank you all. Thank you, OhioHealth, Bricker and Eckler, KeyBank, Corning, Kokosing, Steve Allen, Dave Blom, and the rest of the gang.